Okay, excellent. Thank you, Elizabeth. It's nice to virtually see everyone, and welcome to this meeting this year. Hi, Ohio and several surrounding states. So I am Josh Utay, CPO and educator. I'm at Baylor College of Medicine, and I want to give you an update on what it's like to practice during the era of COVID. I realize this isn't news for us. We've been at this 1 year, give or take a few hours. And let me tell you a little bit about this presentation. So as a starts off with a love story of sorts. Just for all you single people out there looking for love, just know there is somebody for everybody. My first date with my wife, which was about 13 years ago last week, she noticed the way I washed my hands and was attracted to me for that reason, hopefully among others. Turns out she's an infectious disease doctor, and she is a specialist in, among other things, viruses and human immune response to viruses. So when the pandemic came in, she became in great demand. And I said, hey, let's talk about this. And so this presentation became a way of combining what we do. But in total honesty, my wife, Natanya, now of 11 years, it's a lot of her interpretation, and frankly, seeing patients in the COVID era amounts to seeing patients with modest difference for what someone's specialty is. So I've taken her input and applied it to O&P. So again, hi, I'm Josh, Associate Program Director for Baylor College of Medicine's program. My wife, who will not be presenting today, but she had everything to do with putting this together, is an infectious disease specialist at University of Texas McGovern Medical School in Houston, across the street from Baylor, ironically. Houston's a good place to go if you're sick. So timeline of a pandemic. So on the 31st of December, 2019, the Wuhan Municipal Health Commission reported 44 cases of pneumonia of an unknown cause. It was later determined to be the novel coronavirus, and that began what we know of as this pandemic. However, we didn't know it at the time, but it only took about 4 days after that for the World Health Organization to report on social media of the cluster of strange pneumonia cases in Wuhan. 6 days later, on January 10th, WHO issued infection control guidance consisting of respiratory, droplet, and contact precautions. 3 days after that, the first documented cases were discovered outside of China in Thailand. It took a while for the US to realize what was going on and to make changes. The day the WHO declared COVID-19 to be a true pandemic was the day that the Houston Livestock Show and Rodeo was canceled 11 days early by the mayor of Houston. And this drove home what a big deal it was for me and residents of Houston, and frankly, all of Texas, because canceling the rodeo is as big a deal as canceling Christmas. It is the bedrock cultural phenomenon for a lot of people going back for generations. 5 days later, on March 16th, the Texas Medical Center, the largest collection of hospitals and medical schools in the world, interestingly, was entirely shut down except for COVID management and emergencies. And then within a couple of days, Natanya and I got together and put together a list of suggestions for P&O clinics who must practice in the time of COVID. And frankly, because we are all in healthcare, all of us must practice because patient needs don't stop just because there's a pandemic going on. So epidemiology, COVID-19 is the disease caused by the virus named SARS-CoV-2. So as of this morning, 118 million some odd confirmed cases are known worldwide. Of those, 24 million or so are in the US, and under 1 million of those are in Ohio. There are 2.5 million deaths worldwide. As we know, we passed the 500,000 mark in this country recently. And Ohio, within Ohio, there are 17,662 deaths. So no state is immune, no territory is immune. It's a bad deal. Clinical presentation. Symptoms can range from mild to severe. And I realize this isn't news for many of you. I wanted to review this because it's so important, because it's so crucial that we understand this. Symptoms can start 2 to 14 days after exposure to the virus. What are those symptoms? They can be several of these, it can be all of these, it can be just very few of these. Fever, chills, cough, shortness of breath, fatigue, muscle aches, headache, new loss of taste or smell, runny nose, diarrhea, and so on. And coughing colorful particles is also a symptom of COVID. So those are the symptoms. Clinical presentations, look for warning signs. If someone has trouble breathing or persistent pain or pressure in their chest, they're getting really sick really quickly, it's time to intervene with emergent medical care. So if they can't stay awake, if they're turning pale, gray, or blue colored, indicating lack of oxygen in the blood, it becomes a medical emergency. It's not necessarily that common, but when it hits, it's going to be obvious and you'll know it. However, most people with mild cases will recover in 2 to 3 weeks. A third may not be back to normal by 2 or 3 weeks. And some people who have very severe cases may take 6 weeks or more to recover. There are even long haulers that we know of here, over a year later, that experience prolonged fatigue, brain fog, shortness of breath, and so on. There are some people that have been in the hospital for several months, more or less lingering on life support for months, and some of them can eventually get better. So it's an interesting time to be in healthcare. So how is COVID-19 transmitted? Primarily person to person through respiratory droplets or respiratory droplets. When someone with COVID sneezes, coughs, or talks. Infectious droplets can land in the mouths, noses of people, or possibly be inhaled into the lungs. It's easily transmissible. The droplets can land on objects and then find their way into the body. Because of that, WHO recommends standing 1.8 meters from people. CDC recommends 6 feet or almost 2 meters. We know this now because it's much more common. I wanted to bring it up as a point to say it's not, while it is a virus like HIV, for example, and it probably could be transmitted through sexual intercourse, but it's a whole lot easier to transmit it this way than any other way. So be careful, it's out there. When are people contagious? People without symptoms can spread the virus. People may be contagious for 48 hours or more before starting to have symptoms and may be most likely to spread the virus during this time. This is what makes it such a deadly pandemic. People who don't know they are sick are spreading the virus. People are also contagious early in the illness. By the 10th day after symptoms begin, providing no fever for 24 hours and symptoms have improved, most patients are no longer contagious. However, this can be much longer if they have severe illness or if they are immunocompromised from chemotherapy, from HIV, from a variety of possibilities. If someone is exposed but no symptoms and there's no positive test, then they are considered virus-free only after they quarantine for 14 days after known exposure. So what does this mean? This means if we were all in a big auditorium together, then you, the person to your left, the person to your right, the person in the row behind you could be infected with the virus and could be contagious. We look around the world, we don't know who in our environment could be so contagious. So how does that transfer to us? And how do we carry on and practice in a time of COVID? Well, the trick is to minimize the time you're going to spend face-to-face with a patient. So when a patient is has a visit to the office, the goal is to call them before the appointment and to assess their risk and see if they are a candidate at all for even coming in. If they do not have, if they have any symptoms of COVID within 10 days, then they are not allowed to come in. If they've been diagnosed with the infection within 10 days, they should not come in. They need to be rescheduled. If they've had close contact, maybe with a family member, within the last 14 days, they should not come in, they should wait. If they are coming in, instruct them to wear a well-fitting cloth covering or a face mask. More recently, the CDC has suggested putting on 2 face masks because one can get the other more firmly affixed to someone's face. Minimize visitors. We don't want a family to come in all at once like maybe they used to in pre-COVID times to our appointments, because the fewer people, the better. So if one person can come alone, great. If they need to bring an assistant, that's fine. And by the way, this isn't just for patients. This is for visitors, vendors, family members. Being an educator, I think about referring would-be students to local practices. They should be screened too before coming in to volunteer, even if they say they haven't been around someone. It's a screening process for anyone that's going to come into the building. Again, I want to repeat that this is to minimize in-person time. Before the visit, the clinician should contact the patient. This is in addition to someone else, perhaps from the front office, contacting the patient, assessing whether they are sick or they're even a candidate to come into the building at that time. When a clinician calls, they should assess whether an in-person visit is even needed, or maybe the visit could be done by phone or video. If the visit is needed, perform as much of the visit by phone or visit as possible, and then do only what little bit is necessary in person. What can we do over the phone? Well, interview, history in advance. We can take perhaps some rudimentary measurements. We can arrange for pickup of routine supplies. What might have been an amputee coming in to pick up socks, and someone who came in regularly every few months, and you guys could sit back and chat for a while, might need to be this person picking up supplies at the front desk, being handed their supplies, and never otherwise entering the building. If someone needs a repair, then maybe that could be dropped off at the front door, and then the work could be done, and then notify the person when it's finished. So again, minimizing time in the building to almost none in that case. So if we take this one step further, we are engaging in what's called telehealth. It's not a brand new concept. It's been around since I think the 70s when the term was coined. If the person only has a phone available, so no video conferencing, we can still do quite a bit. We can discern their medical condition, we can discern their history, we can begin to educate someone on their recent diagnosis or the process of providing O&P devices, what sort of expectations to experience. And again, we don't want to tell them that we aren't, we're not trying to be brief because we don't like them. On the contrary, we're going to be brief because we do care about their health and safety. If we have a returning patient, narrow it down and say, all right, what's happened since the last visit? Can we hand you supplies to the window? Can we do a repair? And again, the whole idea is to limit number and duration of visits in person. But if we have video too, wow, we have so many more options. We can observe facial expressions. People can't seem to get away with as much quiet deception. If they want to disguise they're having a bad day, we could probably be more likely to see it on video. We can examine their skin condition. We can have them set the phone or camera just right and do a gait exam, a gait analysis. There are even some apps you can get for laptops or iPads where you can video someone walking and do a rather serious gait analysis if they're walking in one of those two planes. You can assist a family member or an assistant that's part of an individual's personal bubble into saying, okay, this is how you want to help guide them when they take their first steps. This is how you put on a liner. This is how you put on socks, and so on. You could say, hey, do you have a tape measure? Guide them in taking a measurement. And again, maybe we can do some delivery through the front office instead of making an actual patient visit, which we're trying to limit. Upon arrival, when someone does present for their appointment, they need to be screened before they come in the building. They should have no signs or symptoms. So while we ask them in advance by phone, let's ask them again, let's take their temperature again. It should be less than 100 degrees Fahrenheit. And when they come in, there's no waiting room, there's no magazines, there's no staring at the beautiful fish tank. It's get up and go right to a room. If people have to be indoors for a little bit, they need to be at least 6 feet apart. And as is more likely the case, once they check in, it's safer if they wait in their car, if they have a car, or just wait outside until we call them to come in. So again, minimizing in-person time. These digital thermometers are the best. I think these are ubiquitous by now, but they are wonderful. You don't have to disinfect it between patients each time because we're not actually touching them with the device. We want to limit transmission to and from patients. Again, because anybody anywhere could be contagious. All visitors, everyone entering the building, should wear a well-fitting cloth covering or face mask, should cover the nose and the mouth, always and completely. Covering the chin is insufficient. If you have a stack of single-use masks available, that would be great. You can say, oh, here's your mask, you need a mask. If children are really young, they don't necessarily need a mask, but as soon as they're old enough to know what's going on and keep their mask on, it's recommended because they could, if they don't get sick from the virus, they could be carriers of the virus to unsuspecting family members. Have signs and posters at the entrances and in strategic places around the building. They're available from various places at little to no cost. Provide alcohol-based hand sanitizer with 60 to 95% alcohol. Some places said 61 to 95% alcohol, but you get the idea. It's a whole lot of alcohol in there. I can't emphasize this enough. The way someone wears a mask is critical. It needs to be well-fitting. Most of them have a wire that's going to overlap the nose just below the eyes. That needs to be fit and contoured to the person's face in such a way that's pulling back, and they're not breathing essentially out of the side of their masks with the air unfiltered. Very commonly, you'll see people with their nose hanging out, and maybe they have good intentions, or maybe they think they're getting away with something. But if their nose is hanging out and their mouth is closed, they're breathing through their nose. They are not breathing in filtered air, and they're exposing other people around them to the virus. It's not cool. It's not stylish. Please tell them to tuck their nose back into their mask and use it properly. It's a public health concern. This has led to much awkwardness in the community when people don't realize their mask is down or they don't care. So set a good example. Be the one who cares that your nose is tucked into your mask and you're doing it properly. Limiting transmission to and from staff. So not only do we need to be careful about transmission from patient to us and us to patients, but we don't want to carry this virus and give it to our colleagues. All staff should be vaccinated when possible. I would argue, and really my wife would argue, that everyone in the building is in healthcare. And when vaccines are available, get the vaccine. Every one of us in the building, even if we don't have that much patient-facing responsibility, deserves to be vaccinated and should qualify for that exemption in that round. Still assess staff for symptoms and recent exposure. Staff should wear face masks at all times, including in the break rooms. There are cases where colleagues, even physicians, pass the virus to each other because they'll wear their mask in front of patients, they'll wear their mask out in patient treatment areas, but when they get back to the break room, they take their mask off and they'll enjoy a nice beverage, whatever makes them happy, but it's important that they keep the mask on. How can we do this? Well, change your masks out when leaving facility. Keep your mask fresh, so to speak. Use hand hygiene. Designate areas and stagger schedules for staff to eat and drink, ideally alone, but that's really not practical in many cases. So designate areas where people can sit and do stuff with their mask off, like eat and drink water and so on, either outdoors or in a break room with at least 6 feet apart. If we can stagger lunch breaks, that would be ideal. It's not fun. Wearing a mask is not fun. In Texas right now, it feels like summer is coming on. The humidity is rising. Masks keep in heat and humidity. It's really not fun, but hopefully we won't have to do it for too much longer. The more we can wear masks now, the better. So that's the public service announcement. Personal protective equipment is the name of the game. N95 respirator is wonderful, no one knew what those were until just a year ago, and all of a sudden everybody knows what they are now. Um, we again to drive home this message, to wear a face mask well, there's the nose wire, there's the ties rather than the ear loops, although I think manufacturers are getting better at that. Um, Use a cloth mask over a face mask. So again, the single-use face mask with the cloth mask over it, one is going to hold the other down, and it's much more than twice as effective. So the goal now is to wear two of them. Eye protection is huge. So just to contrast this to HIV, if you've been practicing for long enough, you might remember when HIV was new to the system, and a lot of people were very concerned about this. Well, standard precautions came up. They existed before, but now every precaution became standard. So people needed to wear gloves when they begin to interact with patients. When I was a kid, dentists didn't always wear gloves. They would just start working and they'd only reach for gloves if something got messy. Now every dentist and hygienist and other medical clinical professionals wear gloves on a regular basis. So that is considered standard of practice. Viruses find a way into the body in many different ways. And unlike HIV, which needs very, shall we say, guided transmission as an STD, the coronavirus is hardier in a sense, and it can enter the body through the nose, through the mouth, and the eyes. So wearing safety glasses is every bit as important as wearing face masks. And this is something we didn't know early on because people said, "Oh, it must be like HIV." It's not. It's even scarier than that. When you wear safety glasses, make sure they wrap around the face, make sure they fit well. And again, it's not enough to have them dangling down over your nose like we might do sometimes in the machine room. We need them up on our face all the time. When my wife, who does see COVID patients from time to time, enters the room, she's wearing safety glasses that are way up on her face and wrap around and do cover a lot, but she never takes them off. It's an all-day event, just like the uniform. Masks with valves are handy. I've got a bunch of these because I do some woodworking at home, and we have these in our lab, and they're really cool because they've got this little valve that allows for easy exhalation when the breather doesn't want to inhale particulates. While the filter mask is good, what we're exhaling comes out through the valve. It's unfiltered air. It's not good. So this is good for the person wearing it, not good for anyone else. It's a particulate mask, not one for COVID. It's not a medical mask, so we need ones without the valves. Standard precautions include hand hygiene, and you have several choices for this. So soap and water, of course, is the best. There's lots of soap, lots of water. Consider doing this immediately before touching the patient and before moving from one task to another, after contact with a contaminated surface, and immediately after you remove your gloves, because stuff gets on your gloves. You don't want to take it home with you, so to speak. The goal is to sing happy birthday to yourself twice so that it's long enough for the soap to be on your hands and actually do some good. One mistake people make who are very conscientious, they'll be very fast in rubbing the soap all over their hands and rinse it off in a heartbeat. Soap needs a few seconds to work and actually pick up the bacteria, and so that it'll wash off your hands when you use the water. I know this is rudimentary, but it's a way we can stop infections from moving on. It's also important you dry your hands completely. That's part of the benefit of hand washing. If you're without soap and water, you use some hand gel, again, at least 61 or so percent gel, and make sure you get every surface of the hands. This is much better than soap and water in a sense that you can't wash it off. So people are not in a rush to wash it off. They'll continue rubbing their hands back and forth until it's gone. So when it was brand new, it was really quite a hit, and it did much better than poor hand washing. By the way, doing this all day is not a bad thing. Every 10 times you use hand gel, it's good to turn around and wash your hands with soap and water. That's the recommendation. So gel is good. Proper hand washing is even better. In the clinical environment, we know that the virus can stay alive and viable on surfaces. Some say hours, some say days. It's probably more like minutes to hours, the science tells us, but lots of things are possible. The goal is to still keep a clean environment. We want to clean and disinfect surfaces that will touch the patient frequently, that we touch. So what do we clean them with? 10% solution of bleach, very inexpensive, very effective. Up to 90% ethanol is one way, or concentration of hydrogen peroxide. The air disinfectant like Lysol that might make the room smell good, or Febreze that claims to kill bacteria in the air, is not enough to kill bacteria and viruses on surfaces. So clean up the room regularly. I've known of a dental practice, for example, that has a timer that goes off every so often. I think at one point it was half an hour, maybe it was an hour. And every time the timer goes off, something goes beep and everyone stops what they're doing and they clean their respective portion of the environment, a countertop, a doorknob, what have you. So it's a good way to stay clean. How often? Well, it depends what the surface is, and more is better than less, largely. If there is a screening or triage area, clean that twice daily. If there are outpatient rooms, which we would qualify in most of O&P care, after each visit, you can argue before each visit if it's been a while since the room's been cleaned. Hallways and corridors, think handrails, parallel bars. When's the last time any of us cleaned our parallel bars? Patient bathrooms and toilets, regular cleaning with disinfectant is going to help. Just look around and see what kind of surfaces you touch regularly, and it needs cleaning. Interactions with patients. Again, I realize this isn't news to you, but maybe it's a helpful reminder as the pandemic wears on over a year. Avoid shaking hands, avoid embracing people, even if you haven't seen them in a long time. Keep your masks on at all times. Sometimes people get comfortable with each other and they take their mask off. It's sweet, but it's unfortunate because then people can become a risk to each other. Maintain 6 feet apart as much as possible. If you need to get closer than that for, let's say, a physical exam, and then back up again to 6 feet. Wear exam gloves all the time. Think about pens and tape measures. And when you get a fresh one, you can use it or have a patient use it to sign something and they put it back in a different area that could be then disinfected. So it says, essentially single-use pen. Pens are expensive, I get it. Use a pen once and then clean it again. So often there'll be 2 buckets near a sign-in. One is clean pens. Take out a pen and you sign with it and you put it in the dirty pen bucket, and then it becomes something that someone can clean the next time the timer goes off and it's time to clean something. Assistive devices. So if we're going to work on, adjust a wheelchair, adjust someone's cane, or certainly any device, that should be cleaned off too, if at all possible. Wearing a lab coat is helpful. Not always practical, but it's certainly wonderful if you can do it. Technical work. So try to keep benches 6 feet apart from each other. Again, still wear face masks all day. It is a challenge to, just repeat this from before, it is a challenge to keep a mask on all day. It's uncomfortable, it's hot and annoying. It's also kind of easy to forget that when you walk in a machine room to grind on, let's say, a carbon socket, that this fabric mask and single-use mask combination isn't enough. You'll actually need an honest to goodness respirator so you don't breathe in all that stuff, because these are more for respiratory droplets than they are for particulates. So the solution, put on one of these and put one of these on over it. I know it's a lot. That's how to do it safely. If you have a respirator mask with the big canister on the bottom, again, put a mask over it. And if you're worried about how it looks, sign your name to it. Be bold, feature it. Clean devices thoroughly before returning to the patient. Wash your hands and disinfect work surfaces before you bring in the next device or process to work on. New pair of gloves for each project, and spread out across the lab if you can. Vaccines. My wife talks about this daily with family members, with patients, with everyone. So I hear about it a lot at the dinner table. The approved vaccines for this country all protect against infection and serious illness and death exquisitely well. So which vaccine should you get? The first one you possibly can. If you can get an appointment right away with one kind versus another kind 2 weeks, get this one right now. That you get the first one you can. And keep in mind, the day you walk out of the pharmacy having your first shot is not the day you have full immunity. That's just when the process begins. You don't have full immunity till 2 weeks after your second shot. The new Johnson & Johnson vaccine is a single shot, and it takes 2 weeks after that before it confers immunity. So PPE, including masks, should still be worn at all times during healthcare, even if you've gotten your vaccine, even if the patient says they have theirs. We can still transmit to each other. And if we don't get sick with it, we can transmit it to others who haven't had the vaccine, etc. So be aware. What are roles and responsibilities of a CPO in the pandemic? Well, we need to keep seeing our patient, first of all. We need to engage in O&P care as we always have, while at the same time minimize chance of transmission in and around our clinic. Prevent people with symptoms from entering at all. If people have symptoms, isolate them the moment they're here. Limit or prevent transmission in your own practice area by using these precautions. Decrease how many people come into the clinic and how long they stay. If 10 minutes can get it done, don't stay for 20, 10 minutes and they're done. And finally, serve as a role model for the world out there. Masks have been the subject of some ridicule, and that's not because of the science, that's for other reasons. If we as healthcare professionals follow the best possible example, we are serving as role models. Get vaccinated, tell others to get vaccinated. The more quickly more people can get vaccinated, the better off we all are, and the better off society will be, so to speak. So in summary, COVID is transmitted by respiratory droplets even before people develop symptoms, or by people who never even have symptoms. So that could be you, that could be anyone around you, which accounts for most of the rest of this presentation. Minimize the amount of time around people in a clinic so that we can decrease the chances of infection among patients and our colleagues. Wear masks and eye protection at all times in the clinic. Clean your hands often, get the vaccine as soon as you can, and help prevent the spread of COVID-19. So thank you. I'm happy to take questions. If it's not something that I know from my wife, then it's something I'm happy to ask her, something we can look up and get back to you very shortly. Depending on the format, well, I'm happy to take questions if there's time.
There is. I already just went and got Brent all set up in the other room, so he's all set whenever anybody's ready. But you're in a separate room, so if people have specific things they want to discuss with you, they could do that here. And if people don't, they can head on over to the 3D printing room.
Excellent.
Thanks, Josh. That was awesome.
Thank you, Elizabeth.
I put your survey in the chat for everybody to do.
Please.
You're in charge. I'm gonna head over there, and you are co-hosting. So when you get tired, you can just kick everybody out.
All right.
Okay.
Thank you, Elizabeth.
Roger probably has questions for you, because Roger's a very good participant, and he has questions for all the presenters. So we appreciate that. Thanks, Roger.
Excellent talk, Josh. That was great and highly germane to what we're dealing with. I've seen patients every single day since the pandemic began. And boy, what a pain in the butt it is. And not to mention just the additional cost to the O&P community
Yes.
in general.
Yes.
You know, we're not getting reimbursed for the thousands of gloves that we're putting on, and all the masks that we're buying, and the Perel hand sanitizer, and providing gloves and thermometers. And sure, PPE dollars, you know, are supposed to go towards all that stuff, or PPP dollars that everyone got, but that was used on payroll trying to keep people employed. So how are you dealing with that in an educational environment?
So we we act as if everyone has the virus every given day, so to speak. So everyone wears a mask at all times, and eye protection, because they all have it with their safety kits anyway, much of the time.
What if they have glasses normally? Do they wear eye protection over the glasses?
Absolutely.
And every day in your office, that's what happens.
Yes.
Wow.
However, it's, well, not always over glasses, to be honest with you.
Okay.
I try to wear my safety glasses every day, but invariably I'll walk out of the machine room, having been in there for some other reason, to take my safety glasses off, because as muscle memory, hours will go by before I realize, oh dear, we're in a pandemic. I should put these back on. Right. In the relatively early days of the pandemic in China, they went back and did an assessment of people who came in. The first, I don't know, so many hundreds or few thousand patients that came in, people who wore glasses all the time, people who were nearsighted basically, were infected with far less frequency than their counterparts who wore no glasses or wore contacts.
Wow.
So I see you wearing glasses. If you wear them more or less all the time, you're at a better place than people who don't wear glasses. And going over the glasses with goggles is even better. And I know it's kind of a drag.
What if you wore a KN95 mask and then put a cloth mask over it? Are you equally protected?
Yes. By the KN, do you mean the valve?
No, just the masks that now say KN95 that come in the little blue separate packs. I don't know if you've seen those. Right. They have no valve, but they register as a KN-95, not an N95.
What's the K stand for?
Apparently, it doesn't have the same standard as the N95 does. It's used in a different industry, not a medical industry. So consequently, I don't think it's not going to be graded by that business that grades the masks. I forget the name of that company, but they don't grade it. But it does have a classification of a different type of mask. So we're seeing that a lot. I mean, I'm going into hospitals and watching some of these people walk onto the elevator with this KN95 stamped on the front of the mask. And I was just curious if you had any knowledge or opinion of that.
No, but I'm going to look it up now.
If you would.
Heard that, and it didn't really register. So thank you.
No problem. It's funny because a lot of what I'm seeing is a lot of that stuff is regional as well. According to the supply chain, here's the manufacturer's mask we're seeing in Ohio versus somewhere else.
Excellent point. And maybe I don't see it because we're close to the hospitals and that's the same supply we get. And I guess being part of an institution, I don't think about it much. There's always a supply of masks and gloves and so on.
Yeah, you're blessed. There was times I was wearing the same mask for the whole week. Yeah. I mean, the same mask the whole week and reusing that mask by putting it in a bag, leaving it there for 3 weeks and rotating it back out again. I mean, it was literally, we could not get masks. It didn't matter what supply chain we went to. We're currently buying our hand sanitizer from a little bitty local pharmacy in our town of Akron, Ohio, because they have access to it and people haven't found out about them. So we're buying it from this little bitty pharmacy when you would think we would have access. And by the way, Perel is in our hometown and we still can't get Perel.
Oh my goodness.
Yeah, it's amazing how regionally there's shortages out there. But I just wanted to thank you for a great talk, very germane. And I'm going to take some of this information back to our facility.
You're very welcome. I'm glad it could help, and I'll pass that along to my wife.
Thank you so much.
Yeah. Thank you, Roger.
Hey, Joshua.
Hi.
Thanks for a great presentation. Hey, have you found, thank you. So getting vaccinated for healthcare facilities that aren't part of a big system, are you finding that it's difficult for them to find somewhere to get vaccinated? Or is there any tips or tricks to that? I know the big healthcare systems take care of getting their employees, but what about the smaller healthcare providers?
So it'll differ by state because the states will have different level of influence in terms of how they get involved. In Texas, um, the medical institutions are doing it differently from one to the next, and it's causing some friction. Like there are a couple of hospitals in town that everybody's been vaccinated. Even the people that come in at night and sweep up floors, they're vaccinated. Whereas we have some frontline peoples at the next neighboring institution that are still not vaccinated. Um, I I was we qualify because we work at a medical center, but because we're not seeing patients, we're not the same priority. I went to a local pharmacy. There's a regional grocery store that's big in Texas called HEB, and they've got a pharmacy much like Kroger's or any other grocery store. And I was able to get in one day when someone else canceled. So I got my first and I get my second in a few weeks. CVS has a similar system where if you can get in and sign in ahead of time, then you can be vaccinated on their list. So I'll recommend CVS only because I know their online sign up system is national and very well organized.
Good. Well,
Does
thank
that
you.
help?
And thanks for a great presentation.
Oh, you're very welcome. Glad I could help. You're welcome. Okay, I've got some thank yous, so I appreciate that. Some people got the vaccine through their employers. So Tiffany Graham, who gave the talk before mine, I believe, it is her husband, who's a dentist, who set the timer for every 30 minutes or so. And when the timer goes off, everyone stops what they're doing and they go and clean their specific area. So thank you, Tiffany, for that anecdote that came into my talk. Guys have any more questions? I don't know if it made national news, but our dear governor signed an order saying that people don't need to wear masks anymore. It's recommended, but it's no longer required. And all the scientists are going bananas saying, don't listen to them, wear a mask anyway, set a standard. So we will continue to set a standard. Thank you all for the opportunity to be a part of your conference. I would happily come back again if there's room, and keep in touch. I'll put my email here if you're interested. Oops.
Cool. Thanks.
You're welcome. That was fun.
I look better on the other camera, so I'm going in that room.
Okay. Thank you, Elizabeth. I'll see you.
I'll talk to you
next
soon.
time.
Thank you
Okay.
for doing
You're
that.
welcome.